All right. Thank you, everybody, for being here. Um, I'm here with Cara Page and Anjali Taneja, and we're talking about your 10 years of work on the medical industrial complex. And I'm really happy that we get to talk about this. I've been dreaming that this could be a way that we could start sharing some of the work that you did. And our Doctors for Global Health General Assembly family is a multi-generational group of people from around the world who's interested in health and human rights issues. And what we practice is, we call it liberation medicine. And Doctors for Global Health is a little bit of a misnomer. We have people from all walks of life. So this might not be something that some people who are participating in this conference have ever thought about before, but I think what you'll find is that it will sound familiar around a set of values that we all share. And so we're really pleased to have you here talking about this important work. And so maybe we could start with each of you introducing yourselves, and also wanted to give space to Susan Raffo, who couldn't be here with us, but who's also part of your core team. Go ahead, Cara, if you want to introduce yourself.
Oh, sure. I'll kick it off. Thank you so much. It's an honor to be here, especially with my co-conspirator, Anjali Taneja, and as you've said, Susan Raffo, who wasn't able to be with us tonight, but is always here in powerful spirit. It's been such a powerful journey we've been on for 10 years. I am currently in Brooklyn, New York, by way of deep work against or transforming the medical industrial complex that started in the South in Atlanta, Georgia, with the Kindred Southern Healing Justice Collective. And right now I'm steering a new project called Changing Frequencies, which is an international project that looks at the locations of sites of harm where the MIC has experimented on or exploited Black and Indigenous bodies in particular, and doing site-specific installations to honor and pay homage to those that have died or been deeply impacted by that colonialist project. Thank you.
And I'm Anjali Taneja. I'm a family physician and organizer, and I'm in Albuquerque, New Mexico on Tiwa land. And I am the executive director of a nonprofit integrative clinic built from the ground up called Casa De Salud. I also do ER emergency room shifts on the Navajo Nation at Crown Point Hospital, and have been doing work around structural inequities and health justice and healing justice in my career, and am so excited to be here. Doctors for Global Health has a really special place in my heart, and was part of liberation medicine is such a huge framework for me in medical school and all the way beyond.
Great, thanks. And so I think we can take this time to have you start your slideshow. And I know that there's so much that we could talk about. This could be a 4 to 6 hour conversation, and we're really not doing it justice to just do this introduction. So we're just gonna honor what we have available to us to the next 30 minutes or so. And at the end, we might ask a few questions if there's time. So go ahead and take it away with the presentation.
Great. So I'm going to take this first part. And we always like to ground in some of the visionaries that have built this work, this transformative work around intervening and transforming the medical industrial complex. So on this next slide, we want to honor Aurora Levins Morales, Latinx organizer, disability justice organizer, writer, leader in movement, who has written many books on the role of healing as integral to our political liberation. And from the book Kindling, Writings on the Body, this quote, one of my favorites, what our bodies require in order to thrive is what the world requires. If there is a map to get there, it can be found in the atlas of our skin and bone and blood, in the tracks of neurotransmitters and antibodies, We need nourishment, equilibrium, water, connection, justice. This and so many of her words and the many words of so many Black, Indigenous, people of color, queer and trans, disability justice folks that have deeply shaped the vision of the medical industrial complex timeline, which I'm going to take a moment to introduce as a project that's been co-curated by Anjali, Susan Raffo, and I, with many hands in the mix, many people that have helped us shape this project for the last decade. On the next slide, we just want to introduce you to a project that will eventually launch digitally. The Medical Industrial Complex Timeline is mapping from the 1400s to now the historical, really the colonialist project of how the history of scientific racism and medicine has been used as an extension, or the way it has been used by colonization and slavery, as an extension of state control, policing, and violence. Excuse me. Excuse me. And what we're doing is mapping the dates, the times of experimentation and exploitation in particular of Black and brown bodies, disabled bodies, queer and trans bodies, Indigenous bodies, migrant bodies, incarcerated bodies, many communities that have fallen subject to heinous, harmful abuses that have happened inside of the MIC, where we are, certainly in this conference, holding the contradictions of being inside a historical legacy that has caused harm, moving towards liberatory practice that can transform the harm that has occurred. And this timeline really shows ways institutions have used scientific racism and medical colonialism and racial capitalism to define marginalized communities as less than human. And we're using it so we can track also the resistance to that ideology, the resistance to the many ways that the MIC has created a paradigm of violence and then an extension of state control. So on this next slide, we just wanted to introduce ways that we are mapping and have been mapping for the last decade the role of generational trauma from the medical industrial complex. And what we really center in our work as a team of across disciplines as healers, as cultural workers, as organizers, as doctors, Anjali, Susan, and I, with many others that are sitting with us asking the question, how do we heal and transform the trauma of exploitation and experimentation through the medical industrial complex, as much as we're looking at through the prison industrial complex. And at this heightened moment, it is at the nexus of white supremacy, of ableism, of adult supremacy, of patriarchy, of Christian supremacy, and heteronormativity. We're understanding the relationship to how many of our communities, many marginalized communities have experienced so much testing and harm and trauma from the MIC that has been deeply embedded in colonization, slavery, capitalism, systemic oppression, eugenics, and population control, that we understood a gap in really shifting the paradigm and shaking up the analysis of when we're talking about abolition, when we're talking about liberation, especially in relationship to medicine, how are we holding the question of historical and contemporary practices and the trauma that has been passed on through generations from these practices, harms, and abuses? And so we want to share with you a shared definition of the medical industrial complex that deeply roots our work. The MIC is a system that, one, relies on wealthy, or this idea of wealthy, white, cisgendered, heterosexual, able-bodied male and Christian ideals as defining whose body is healthy and whose is diseased. And I often call on Patty Byrne, who's a disability justice organizer and architect of disability justice as a queer woman of color, director of Sins Invalid, who always speaks to whose body is pure and whose body is sinful, is deeply embedded in this idea of the healthy body. The MIC also prescribes who is expendable, as we know, who is deserving of access to quality and dignified care, not only physically, but spiritually, emotionally, psychically, environmentally, and mentally. A care that is dignified, and who cannot access that care. We also believe the MIC, on the next slide, determines whose body is criminalized and pathologized based on what is beauty, what is desirable, based on what bodies are fit and unfit to survive, and who should exist for the purpose of labor and production for the wealthy elite. And also, the MIC is an extension of state control and violence and uses institutions, privatized public health institutions, as a platform for surveillance, policing, and erasure of those seen as expendable, uncured, unfit, and abnormal. And finally, we see the MIC as really, in particular in this moment of COVID-19, relying on a doctrine of fear. How do curative models and then disease-based capitalism enforce and militarize a global response of care under this false guise of global security? This idea of those who are diseased are somehow a national threat. So how do we criminalize those who are seen as diseased or expendable, but also criminalize practitioners and traditions that are outside of Western-based models of care, if they cannot be used to militarize disease or be used to capitalize disease. So we're looking at this at the MIC always through a racial capitalist lens, through a liberatory lens. And I'll end with and pass on to my co-conspirator, Anjali, this next slide of, when we look at the timeline that we're co-curating together, we see this as the backdrop to what is possible in building a future or multiple future strategies around how we transform these archaic ideas of science and medicine steeped in racist, colonialist, transphobic, ableist notions of care. And we're always looking to those who have created such major transformation through the organizing and the actions they have taken. And on the timeline, when we share it, you'll know there'll be a whole line of resistance. And we wanted to lift up just a few, there's many, but one being the Young Lords, the Latinx movement in the 60s and 70s that organized throughout the country for racial justice. But in particular, in 1970 in the South Bronx in New York, the Lincoln Hospital was known as having some of the worst care in New York City. And Young Lords organized and took over the hospital and insisted on dignified quality care, shut it down, and organized a whole takeover of the hospital until they were able to get their demands met for, maternal care, better treatment by the staff, because they were experiencing immense racism and classism every time they entered. And they also took over an ambulance so that they could also ensure that when 911 was called, that actually the hospital was servicing their communities in the South Bronx, because often they'd call 911 and no one would show up. So they actually commandeered ambulances to take to people calling for medical support. And another example is Black and Indigenous birth workers in the South. In particular, after slavery, what we know to be true is a history, a deep, rich history and legacy of Black and Indigenous, mostly women, birth workers in the South, who were holding the nexus of life and death and care for many communities, formerly enslaved African and Indigenous communities after slavery, and that we still deeply revere them as being the front line of resistance in being able to ensure the existence of future generations. And I'll pass it to
Anjali. Thank you. I'm speaking on behalf of Casa De Salud also in this moment as a present time example of a part of the lineage of resistance, along with many other models of care. We're an integrative clinic serving mostly uninsured patients and some folks with Medicaid. Actually, our Reiki master and ear acu-detox specialist learned ear acu-detox in the early days at Lincoln Hospital, as that was a self-help model for supporting people with addictions, withdrawals, cravings, stress reduction, anxiety, all of that. And so this model combines Western conventional medicine, unpacks the biomedical model quite a bit in the way we even approach Western medical care, but also integrates Reiki, massage, acupuncture, indigenous-based healing circles in a culturally rooted way that rebuilds trust with the community and does the opposite of the way that MIC kind of criminalizes healers of different practices outside of Western medicine. And in our addictions work, we do a lot of work going way beyond the biomedical model and looking at collective care and the impact that solidarity and civic engagement and other things can have on patients and community members who are struggling with generational poverty and traumas and things that structurally affect rates of addictions. That's another example. I'll shift over now to the moment right now. We are in quite an interesting time, this abolitionist moment in capital letters, with the intersection of the COVID-19 pandemic that has obviously shown all the fractures in our for-profit medical industrial complex, and shown the ways in which structural inequalities and current political decisions around health and public health are imprinted on people of color in America. At the same time, we are seeing quite an important nexus with the Black Lives Matter movement, which obviously is, almost a decade old as a movement in of itself. Brutality by police is not a new thing, but after the death of George Floyd after the murder of George Floyd in Minneapolis, this has become a national and international awareness, and people are speaking up, working in solidarity with each other, and really thinking differently about how we can structure systems that surveil us and that create problematic interactions with criminal justice, and that contribute to racism in such strong ways. So all of this is coming together in this moment, which feels to us like a really, really important conscious time to connect histories to the present so that we can help shape the future. There are White Coats for Black Lives chapters around the country. There are spontaneous moments and movements by healthcare workers also, and that feels really important. There's a unity now that it has been hard to come by in the past that really makes this an important moment. What we are aiming to do is to house this timeline of history that Susan Raffo, Cara Page, and I have worked over the years to put together, and really look at the history from colonialism in America to colonization in America to now, up to this moment in the middle of the COVID pandemic, and share knowledge with the world from what we've put together. And like Cara said, a host of other folks, research assistants and team members have put together. And we are working through a way to share this. You saw a 2D version of it that Cara shared in one of the slides. And we're working with some other ways that this can be something that people interact with a little bit more than in a 2D version, and kind of walk through different pieces of history, and kind of turn a corner, if you will, to see what connection that piece of history has to something related to their family, or to see what that piece of history has in relation to something in the present that someone wants to learn more about for context in the past. Earlier in this slideshow, the timeline moment that was noted was Dr. Sims experimenting on enslaved Black women without any anesthesia in pure experimentation because they were lesser than and they could be experimented on. And they took those lessons and then applied them to serve white women with the highest levels of anesthesia and pain control. And he's known as the father of modern gynecology. And I just, would share that in my medical school experience, we did not learn that piece of history. So it is so important to know that piece of history, to know how we can intervene now and think about, radically imagine what our future can look like. So with this timeline, we're building out a curriculum as well as a digital hub and network that feels very important. We have goals of people really understanding the timeline, but also thinking about how does that connect to what I can do now and who else is working on something that I'm interested in working on now. So it's so critical to root in the historical and contemporary practices of the medical industrial complex, and for all of us to really understand our own roles in it. What harm have I played? What context or institution history do I kind of live and work in? And how do I think about transforming that? And we're aiming for this to be a generative space that can connect people locally and globally. Folks that have ideas where they are in their local spots working to transform the medical industrial complex, whether that's something small but really impactful that they can change in a hospital environment, or whether that's creating a new system of care, or whether that's any of a million other things. And a place where folks can share tools for interventions. We can, if I'm interested in building something, who else can I talk to who's already built it and level up those ideas and learn from what failed to not repeat that again, so that we can together and individually work to interrupt and transform the medical industrial complex. Bringing in Susan Raffo's energy around this, she could say this much better than I could, but this work to us feels like the rhizome net for the milkweed and Joshua trees. The monarch butterfly caterpillar relies on the milkweed, and the monarch connects the northern and southern hemisphere. In this way, if we have a hub that connects the past, the living memory, to the present, so that we can take that and create different futures for ourselves and our communities, that is exactly what we are trying to build. And so this digital strategy, this hub and network, connecting the past to the present and future, is in service of this aim of creating living memory. And this is our team. Susan's website, myself, and Cara. Stop there.
Yeah. Wow. Thank you so much. I think maybe at this point we'll wrap some things up, but I wanted to maybe just talk again a little bit now that we've gone through the project work and we've learned more from you. I'll just use myself as an example, but hopefully this is how other folks in Doctors for Global Health and who are here at this presentation will take this. Anjali, you said that part of the project work is for people to ask themselves, where am I centered in this? What role do I play? And how do I transform that? And I think that was one of the reasons why I really was happy that we get to share this in this space. Right now I'm working in Watts at Martin Luther King Jr. Community Hospital, and you and I did our training in Torrance and another part of South Los Angeles, and that's where I've worked my whole career. And I'm not from there, but I've been invited to do this work, and I've been working in the community for over 12 to 14 years now, I guess. And I'm so grateful to this work and the medical industrial complex, because when I look around, especially with COVID-19 and this global pandemic, the way that you share this is really the only way that I can really understand what's going on around me. And so, I just think so many people don't even get the opportunity to think about things in this way. We're thinking about our job as a doctor, or, how to survive this shift or whatever it is. But so many things have come up, and when we do this work, we're not necessarily the ones that are experiencing structural racism or this generational trauma, but we are walking hand in hand and in accompaniment with people who are. And this pandemic has just really brought up so much for us. So, I just think this perspective, if we don't understand this history, then we're not going to understand how to fix what's going on. And so that's why I hope that this just gets shared more and more and more. And I can't wait for the timeline to come out, because this is where I see solutions to start, or these conversations that we're trying to have. And, the things that I see going on around me in Watson Compton, there are just so many people who are essential workers, who are living in crowded homes where everybody's sick, and people who are undocumented are afraid to get tested. They're afraid that ICE is going to be at the testing sites, and they're taking all the hits for society. And at the same time, we were at risk of getting a $30 million budget cut in the middle of all this that we narrowly missed by pouring all of the hospital's resources into lobbying just so we could save our budget, which is already not enough, And when Black and brown people are dying disproportionately, it's just insane to think that that's what's happening. So this work kind of drives us forward, and it helps us find our way when we're within these spaces. How do we figure out, how to yell loudly and how to kind of help people get what they need? I don't know that my colleagues always see things the way that I do. So if I'm talking at a medical staff meeting, you guys are kind of with me if I feel like I can't find my way. Some of the things that have come up for us were about, there's this emergency use authorization for remdesivir. And, that's certainly not going to be the thing that helps us get out of this pandemic, but we got, a bunch of free medication, and we were learning what we were supposed to do with it. And in order to get this free medication, we had to give a bunch of information to the LA County to track who's getting the medication, including age, gender, zip code data, et cetera. And we weren't necessarily telling people that, and I insisted that we tell people that that information was being collected on them. And I got a lot of pushback, we don't have to do that. It's not part of the EUA that we have to tell people that this data is being collected. And I said, it still needs to be told to people. Just because it's not, just because the government didn't tell you that, we still have to tell people, this is what this is all about. And that's just such a minor piece, but I don't know that I would have been able to say that out loud if I didn't learn some of these things from you, Anjali, or other folks kind of doing this work. So sorry, that was kind of a long reflection on what you do, but I'm also part of our bioethics committee at the hospital. And at the beginning of the pandemic, we were just in deep fear over what's going to happen next, and we had to start thinking about what crisis standards of care would be. And part of me was just saying, we're always practicing crisis standards of care. This is kind of what we already know how to do. Why is this so do we go deeper into this crisis? Kind of how is this framed? Why are other people not already like this? What is happening here? And then realizing, oh, the pandemic, we're not going to start sharing resources any differently just because there's a pandemic. People who have been marginalized are going to be more marginalized, and people aren't going to suddenly go out of their way because this is a pandemic. And if it weren't for, your voices here, or, other people who were really, really strongly advocating for different ways of thinking about crisis standards of care and who care gets rationed to, like Kamara Jones. I don't know that our bioethics committee would have necessarily known our way, but we were able to make really strong stands about what is appropriate and what isn't. And I think that just needs to be expanded to talk about what it's like every single day as opposed to like what's happening in the pandemic. So I don't know, and you know, we don't necessarily have to share all of this during the General Assembly. We can, you know, push record or share just parts of this. But when you guys are thinking, I mean, I'm rooted in the healthcare system, so health is so much more than that, public health, and then just the way that we run our society. But when you're thinking about the MIC and the timeline in the future, how do you want to share that with different groups of people, or what do you want people like me who are sort of in these broken systems doing the best we can, like how do we start to, you know, we're here in it, but how do we transform it from within? Like I'm doing my best, and I do it sort of at a committee level and inside and outside of work. And I think it works a lot better outside of work, but it also has to work inside of our workspaces and inside of our broken systems, right? So how do we kind of take this and start to do the transformation? Easy question, right?
We actually have that. We have that strategy. We are building a political education tool like the timeline, and there's been other work that all of us have respectively been building that's rooted in healing and health justice, that looks at intervention strategies where we don't want you or anyone to feel that they're working in isolation. From a health practitioner to a healer to a birth worker that's holding care and safety at the nexus of community or movement, and seeks to transform the system, but we don't want them to feel that they're doing it by themselves or that all of these incidences are not somehow in relationship to each other. So we've actually sort of loosely created a cohort of people already that we've shared the first or maybe the third iteration of the timeline with, and we'll be building a curriculum and an institute that gathers more accessible information, but also helps practitioners to map conditions, explore strategies, see what's happened on the ground. And as Anjali mentioned, this digital hub will allow us to cross-generate some blueprints of what's working, or what did you try on your bioethicist committee around disability justice, or in the hospital being complicit with state through inviting ICE or police investigations. There's so many ways people are actually confronting and intervening. And so we are merely creating a generative space for folks to acknowledge those strategies and build and leverage off of them with each other. I'm sure Anjali wants to add to the mix.
No, that's right on. I know that's so much, especially working in a system that in many ways doesn't